Hey guys, it is Brandon and welcome to episode number 3 of the How to Ace Your Unseen Case video series. I look an absolute mess today and I'm actually exhausted. I've been at work for 3 days this week already after a week off. So I should be recharged, don't really know what's going on. So if you're a budding dental student watching this, or you've got your finals coming up, then I would say have a long hard look in the mirror. Consider your life choices up to this moment and think, do you want to look at teeth all day, every day and come home absolutely exhausted? Hopefully you haven't clicked off the video already because obviously I'm kidding. I absolutely love what I do. It can be tiring, but I think I'm just tired from the fish and chips that I've just eaten. That's a complete random tangent. So this is episode number 3, but it's coming out after episode number 4. And basically what happened is I recorded episode number 3, edited it all, prepped it all, had it ready to publish, and then I realised it had been formatted wrong. And it was heartbreaking because I spent like 8-9 hours kind of planning it and recording and editing it, only for it to be completely useless. So I already had episode number 4 kind of in the works. I started producing it already. So I thought, you know what, I think that would be a little bit quicker to push that one out and then redo episode number 3 when I've got the motivation back. So that's basically it. So check out the videos that I've published previously if you haven't seen them already. They're a good kind of build up into today's episode. Well, basically we'll be talking about all things endodontics and periodontics. So basically, yeah, going to run through everything you need to know regarding endo with a lot of references. Key information of the things you need to know regarding perio, so old guidelines, new guidelines, which classification is good, and kind of putting that into practice. And then at the end, there's a nice case example, combining the two from someone that I saw on my as a patient this year. And what we'll do is I'll put the case up, like the oral surgery video if you've seen that, pause the video, do it as if it is an unseen case. And then afterwards there'll be questions that you can answer out loud and that I'll give a video response to as well. So yeah, that's about it. I think we'll get stuck in. Like always, the support is great. I appreciate it. I've had people messaging me on Instagram with a few questions and some feedback, which has been really nice. So please give me a follow over on Instagram. It's at TillerTalksTeeth. Give me a follow on YouTube or a subscription. Please like the video and just engage with me because I love it. I love teaching. I love when people ask me questions, challenge things, have queries. It just makes it a little bit more exciting and motivating for me as well. So without further ado, let's get stuck in. So let's jump straight into endodontics. And basically, I think the first thing it's important to establish is a good diagnosis. Like I spoke about in episode number 2. You can't just jump into a tooth and do a root canal straight away. You need to have a good justification for that, and a good justification is coming to an accurate diagnosis. So we're talking things like special investigations, guidelines for diagnosis, and then basically making that decision. So we'll run through all that now before we actually talk about the procedure itself. So I'm not going to linger on this in this first slide for too long. We spoke in depth on episode number 2 about special investigations, and essentially I've just copied and pasted this slide over as a refresher for the things that you can be doing and looking out for to ascertain your diagnosis. So they're basically just refresher things like what questions you can be asking in your pain history, the signs you need to be looking out for, and the things you need to be investigating in your clinical exam. So things like special investigations and sensibility testing, and then also the radiographs that you should be taking. So please check out episode number 2 if you haven't seen it. I talk in a lot of detail about the special investigations that you need to do, why you do them, and what they help you kind of find out about the patient and understand. And it's really good and useful to be able to have a good kind of a good understanding of that before we talk about diagnosis itself. So when I like to think about giving a diagnosis, I like to break it down into 3 sections and then bring it together for a complete diagnosis. And basically, when someone is examining you, so when it comes to diagnosis, I like to be clear, I like to be concise, and I like to consider the whole of the tooth. So what I basically do is, and if there's anything you're going to take out of this video, I think this is probably going to be the most important section. Whenever I'm doing a diagnosis, I split the tooth into 3 sections, and then at the end I bring it all together and I give a complete diagnosis. So what I will do is I will split it into a coronal kind of diagnosis. So this will be any pathology that you can see in relation to the crown. So be it caries, fracture, tooth surface loss, cracks and things like that. Anything that you can see clinically, radiographically, that may or may not relate to the symptoms. Then I would give a pulpal diagnosis, and then I would give a periapical diagnosis. And once I've got the 3 of them, I will bring them together, and that will be my complete diagnosis. And there'll be an example of how I do that in a couple of slides' time. And the reason that it's so important is because when you're giving a diagnosis, it's so easy just to focus on especially during an exam, it's so easy just to focus on the problem at hand. And as dentists, we need to focus on the bigger picture as well. So even if you know that from the clinical presentation and special investigations, you are 100% certain that a patient's got symptomatic irreversible pulpitis, if you're presented with a clinical picture or a radiograph and there's evidence of caries, even if it's so obvious but you fail to mention it, the examiner will just assume that you've missed that, and it's a red flag. It's a big no-no in dental exams and diagnosis. So you have to be explicit with the things that you are describing, and you need to put them down in a concise and an accurate manner. So the next few slides I'll kind of run you through how I come to mine, and hopefully at the end it'll be very clear on how to get a really good, accurate diagnosis every single time and show an examiner that you can competently get to this level, and you can justify why, essentially. So the first thing that you want to do is you want to describe anything that is coronal, and more often than not it's going to be caries. And even if it's not, this kind of what I'm going to talk about will kind of relate to things like fractures and deficient restorations and things like that anyway. It's basically about describing what you can see, where it is, and what the extent is. And it's all well and good putting caries, but if you were just to put caries on the lower left 6, for example, it's not very explicit, and caries can differ with your treatment plans quite significantly. So, for example, if you have caries into the enamel versus caries into the outer 2/3 of dentine versus caries into the inner third of dentine or into the pulp, your treatment plan, even though they're all caries, your treatment for the 3 is going to differ massively. So if you don't put the extent and the site of the caries and you do a certain treatment, it might not be quite clear that you have the justification to do that. So for example, if you do an RCT on a tooth, perhaps the caries is into the pulp, then there is justification. But if you adjust the right caries, then the examiner or someone reading your notes could interpret that completely different and say, well, why has this person done a root canal? And there's lots of ways that you can classify caries itself. A very common one to use is the SDCEP one, so the table on the top left of the screen. And essentially what they do is they describe the surface, so occlusal or interproximal or both. And then they will describe the extent at which the lesion extends. So is it initial, is it moderate, or is it extensive? Very easy and very explicit. The second thing you can do is the ICDAS system, which is a universal and very commonly used one. And ICDAS, I think, stands for International Caries Detection and Assessment System, I think. Not 100% sure, but I'm pretty sure it does. And basically what that does is it describes it based on what you can see visibly on the tooth itself. So looking at things like discoloration, cavitation, and things like that. Again, a very easy tool to use, but perhaps I'd say the one drawback of the ICDAS is that enamel and dentine behave very differently with caries. The way that enamel works is you have caries typically starts in a fissure, and you'll have this little pinprick. It's like an upside down umbrella. Because the enamel is hard and mineralized, as soon as that reaches the EDJ and hits the dentine, which is slightly softer, it mushrooms out like the bottom of an umbrella. So if you think, I've conveniently got a tooth drawn there, if you think that the caries starts just in there in the fissure and you have the enamel there, what happens is the caries will go down, 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 And as soon as it hits the dentine, it will spread out like an upside down umbrella or a mushroom. So I think the issue with ICDAS is you can look at something and it may not tell the complete picture of what is going on below the surface. So the way that I like to do it, and I kind of have taken it from the European Society of Endodontics guidelines, the Managing Deep Caries and Pulp paper, is I like to do it radiographically, and I like to do the extent of the caries itself. So what I'll do is I'll comment on the surfaces. So is it occlusal, mesial, distal? And then I will comment on the extent of the caries. I will say it's either enamel, into enamel, it's either into the outer 2/3 of dentine, or it's into the inner third of dentine, or it's into the pulp. And very similarly to the picture on the bottom left, the radiographs there, but the outer third of dentine and the middle third of dentine will be together. So that's the way that I like to do it. I'll show you an example of that in a few slides' time. But basically find something that works for you, something you can use consistently. But all of these are acceptable ways to describe caries. So once we've ascertained our coronal diagnosis, then we need to be looking at what state is the pulp in. And it's good to have a pulpal and a periapical diagnosis because at the end of the day they present differently and they're separate entities. So I like to use for both my good friend, the American Association of Endodontics guidelines. They're brilliant. They are so clear, so easy to understand, and define the symptoms so nicely. So a really good document to look at is if you just Google American Association of Endodontics, and then the title of it is called Endodontics Colleagues for Excellence. And it's basically got a blue front cover. It looks very old school, but it runs you through pulpal and periapical diagnoses really nicely. And I've summarized it on the tables on the next couple of slides. I'm not going to run through them. Just have a look at those in your own time. They're very straightforward. But what they do is this one on the pulpal basically splits it into dentine hypersensitivity, reversible pulpitis, and symptomatic irreversible pulpitis. And you can clearly see from the clinical presentation that you will fall into one of the three categories if you have pulpal symptoms. So it's good to be able to learn this, recognize what pulpal symptoms are, and then at the bottom it shows you kind of how you can manage these things as well. And we have our periapical diagnosis as well. And we have our periapical diagnoses here as well. Again, same paper. And I've summarized it again in the table. I'm not going to run through this. It's something that you can have a good look at in your own time. But essentially how they split periapical diagnosis is up into 4 categories. And it's based on clinical presentations and radiographic appearance. So we have symptomatic and asymptomatic apical periodontitis, and then we have acute apical abscess and a chronic apical abscess. All present differently. They will vary in what they look like in a radiograph, but with a radiograph and the clinical presentations, you can easily put the two together and pick one of these 4 to complete your diagnosis. So have a good look at that, and once you've had a good look at that, we'll move on to an example diagnosis on the next slides. So we've got absolutely everything we need on this slide for a nice example and to make a nice diagnosis. We've got a history of presenting complaint, we've got our special investigations, and we've got a lovely radiograph as well. So like I said before, the way I like to do it is split it into 3 chunks and bring the 3 chunks together, and you've got a really nice accurate diagnosis. So if we start with the coronal pathology, essentially we are just describing to the examiner what we see. We've got a lovely PA of the lower right 7 here with a really nice impacted wisdom tooth next door. And if you're to describe what you can see, essentially you've got caries that's mesial and occlusal, and you've got caries that extends into the inner third of dentine. The main reason that it's the inner third versus the outer third, the main diagnostic factor is the fact that there is no clear band of dentine between the caries and the pulp. So if you look on your PA and you've got a lovely grey band of dentine between your caries and between your pulp, and it's really well demarcated, then you say that the caries is into the outer 2/3 of dentine. However, if, like in this image here, you can't clearly see that clear band of dentine, or if the caries is actually into the pulp, then it's considered into the inner third of dentine. Simple. Next thing we look at is the pulpal diagnosis. So we ascertain this purely from the clinical presentation and the special investigations. So the first thing that we want to look at is there any vitality in that pulp, or is it to the point where it's at pulpal necrosis and it's dead and it's non-vital? So we can see from this case that the patient's worse with hot and cold and a pain that lingers afterwards, and we can see from the special investigations that it's positive to endofrost. Now, if the difference between pulpal and periapical is that if you have symptoms coming from the periapical region, endofrost and hot cold won't affect that. Endofrost and hot cold directly relate to the sensibility of the nerve itself. So we know from this already, the fact that it's reacting to hot and cold, that we have some kind of pulpitis there. What we don't know right now is it reversible or is it irreversible? And then that's where we have to look at the rest of it, the rest of the complaint, and kind of decide for ourselves which one it is into. And basically you can see that the pain lasts for minutes and the pain keeps the patient awake at night. And the pain came on spontaneously. So all of these, if you look at the AAE guidelines, are classic symptomatic irreversible pulpitis. So that's your pulpal diagnosis. Then you need to consider, do you have a periapical diagnosis, or do you just have to write normal periapical tissue? And if you look radiographically, it's not really evident that there's anything going on there. So again, you have to look at your special investigations and your clinical history to decide if you've got any periapical pathology at all. And the real key kind of indicators are the fact that it's tender to percussion and it's painful when you're biting. And then you refer back to your guidelines again, and this is why it's so important to know them inside out. So TTP and pain on biting, you can then accurately say that you've got symptomatic apical periodontitis, and the AAE guidelines say that you may or may not have an apical radiolucency. In this case we don't, but we still know that because it's tender to percussion, there's periapical pathology going on. So it's basically just trying to work it out and piecing it together. And if we put the things together, it makes a really nice diagnosis. We would say that we have lower right 7 with mesial occlusal caries into the inner third of dentine, with symptomatic irreversible pulpitis and symptomatic apical periodontitis. And to me, that sounds nice, it sounds concise, and I think it's something that when I was giving it to my tutors or examiners, they found quite impressive. So get that down, and it's a really, really good starting point. So diagnosing cracked tooth syndrome can be an absolute bugger. It's a bugger to diagnose, and it's a bugger to manage in practice. And a lot of people during the pandemic are coming in. Fractures are so common now. People are leading a stressed lifestyle, so they're grinding more at night. This is also something good to mention in your Viva. People are wearing masks as well, so they're clenching quite a lot. Every time they're talking in a mask, they're trying to work against the resistance of the mask. So getting a lot of jaw fatigue, a lot of clenching, and a hell of a lot of fractures that I've noticed. And it's good to have a basic understanding of how you diagnose and how you manage these things and the things you need to look out for. So I've summarized it here, but I'll point you to two really good papers that are in the BDJ, and I think they're on nature.com now, and they're something along the lines of managing vital cracked teeth or vital fractured teeth, and it's basically split into a part 1 and part 2. It's free to access, and it's really easy to understand and really easy to read, so I'd have a good look at that. But basically, in a nutshell, when it comes to cracked tooth syndrome, the presentation can be slightly ambiguous. That's why it's quite difficult sometimes to diagnose it. So a patient can come in and they can have a sharp pain when they're biting, or so when they bite on something, they might say, well, I've got a shooting pain specifically on this tooth when I'm biting on it. Or they might say something like, when I open my mouth after I've bitten, I get this dull, annoying aching pain every time I release my bite. And to make it even more difficult, they might just come in with symptoms of reversible, irreversible pulpitis in teeth that look completely nice, but somewhere there's a sneaky crack on there. So very difficult, and it's very important to have a good understanding and a really thorough go at special investigations, really to make sure you can nail the tooth that's the issue. And special investigations don't differ from anything else. You are doing things like percussion, mobility, pocket assessment, occlusal assessment, sensibility testing. But the things you can also do to try and find cracks, so you can use a tooth sleuth. So you can ask the patient to bite up and down whilst moving it between each of the cusps of the teeth and seeing if you can get a response anywhere. And you can also do transillumination, where you get you can get your UV light that you use to cure your composite and shine it around the tooth and see if it highlights any fractures. Sometimes can be a really good tool, especially if the naked eye can't see it. Clinical findings, often the tooth will be TTP and positive to a tooth sleuth. That's quite a good indicator of a crack. If a crack's been there for a long time, you may find a deep pocket adjacent to the tooth. So say you've got a pocket depth of like 7 or 8 next to a tooth in a patient that's got really good oral hygiene, then you can quite confidently say that there's probably a crack related to that tooth. And sensibility testing could go either way. If you've got a pulp that's still alive, it will be positive. But if you've got a pulp that is necrosed or dead, then it will be negative. So it could go either way, and your management will be affected accordingly. I've got a nice little flow chart in the next slide that can summarise that. Radiographically, sometimes this can be your biggest indicator. If you can't see a crack and you can't work out for the life of you why a tooth is hurting, take an X-ray. It might appear sound, but what you might see, and this is kind of related to the pocket, is you might see this classic presentation of bone loss like you can see on the X-ray here. And basically you have this narrow, deep pocket next to the tooth because it's an isolated area of bone loss adjacent to a fracture, and it'll radiographically it will present as this classical J-shaped lesion. So the bone loss will follow one of the roots down, and then it will hook under the apex, kind of shaped like a J. You can see on the image it's like a backwards J there, and it's very classical of a cracked tooth. So with cracked tooth syndrome, I've made a very easy to understand, or hopefully easy to understand, flow chart here. And this is a really good way to basically understand if a tooth is restorable and understand how you can manage it based on the presentation. And this is a good little kind of cheat sheet to have when you're treatment planning a cracked tooth. So for example, in your exam, if that is what your diagnosis is, you can refer to this for how you can manage it appropriately. So the first thing you need to look at is where does the crack go? This gives you information, basically, is it unrestorable or is it restorable? And if the crack goes subgingival, or if the crack goes over the pulp roof, you can basically say this tooth has to go in the bin. It can't be restored. We're not going to be able to get an effective seal where that crack is. Bacteria is going to get in there, under the gum, and the risk of it causing a whole host of issues is there. So it's not worth the hassle. If you have a crack that is supragingival, brilliant. Move on to the next part of the flowchart and assess the pulp status. And this you kind of treat it as if you have caries. So if you have reversible pulpitis in a tooth with a crack that's supragingival, cuspal coverage is your gold standard. That will provide a nice seal, it will disperse the forces of occlusion, and because you have symptoms of reversible pulpitis, you should expect the pulp to be able to go back to normal. If you have symptoms of irreversible pulpitis, or you don't have any response to sensibility testing, so there's pulpal necrosis, then you need to have a look at periodontal support. Is the tooth going to be restorable? Because you're now going to be considering endodontics. If you have good support, so lots of bone, good oral hygiene, not loads of deep pockets around the tooth, brilliant. You want to be considering an RCT and then cuspal coverage. If there is poor periodontal support, so the opposite, so no bone, poor oral hygiene, lots of deep pockets, then again, the prognosis is not good. You consider the tooth not restorable and consider it for the bin. When you're treatment planning, you might need to also consider emergency options when you have a cracked tooth, and the most simple ones, if you have a restorable tooth, are occlusal reduction. So you get your articulating paper, assess where the crack is, and assess if there are any high contacts or bites on that tooth, and simply just shave down the cusp so it's out of occlusion. So every time the patient bites, it's a little more comfortable. You can do a composite splint. So this essentially is where you etch, prime and bond, prepare the whole occlusal surface, and you put 1.5 millimeters of composite on that occlusal surface just to kind of act as an interim kind of cuspal coverage and spread the forces of that occlusion. Obviously, when you do this, you're going to be building it up, so you have to warn the patient that it's going to be high. It might be a little bit more uncomfortable, but you're reducing the risk of those symptoms and reducing the risk of the crack propagating. The third thing you can consider is an ortho band, which essentially you just stick a metal ring around the tooth, and it basically just reduces the crack from propagating. Doesn't really do too much more than that, but just tries to hold it together a little bit more. And that's it. We've reached our diagnosis. We're ready to get stuck into a juicy endo. But what are the steps we take and how do we take them? So we'll run through in the next few slides kind of the process, not in too much detail because it's not going to be a massive unseen case question, but I will highlight the key things that examiners might ask and how you can answer these things. So just a couple of cheat sheets on the next couple of slides on the anatomy of the roots, how many canals there are, and kind of the access cavity shapes that you're going for. So feel free to screenshot those and print those out or copy those down. So we need to be able to justify why we're doing a root canal treatment, and there's a lot of indications beyond what we've spoken about before for why you could do a root canal. So you've got your common things which you mentioned earlier: irreversible pulpitis, periapical pathology, or a cracked tooth with symptoms of IP or pulpal necrosis. But alongside that, you've got various other factors. So you have things like pulpal exposure, and when you have pulpal exposure, you need to use your clinical judgment to determine, well, can I get away with just restoring, or do I need to consider endodontics? And it basically, you need to look at the tooth as a whole, and it's dependent on your symptoms, what's the size of the exposure, and what caused the exposure. So for example, if you're doing caries removal in a patient with reversible pulpitis, and you have a pinpoint exposure of the pulp, you just see it blushing perhaps, I think you can kind of confidently say that you can pop a pulp cap on there, restore the tooth, and then review the symptoms and inform the patient that it could go either way. But if you're removing caries in a patient and you hit the pulp chamber, you see the pulp exposed, and there's still soft infected caries absolutely everywhere, you kind of need to understand that that bacteria and the caries has probably already infected that pulp. And whilst the patient isn't symptomatic at the moment, or they don't have symptoms of irreversible pulpitis at the moment, the caries and the bacteria have hit that pulp. If you're to restore that tooth, the likelihood is that the pulp will then display symptoms of irreversible pulpitis, and the patient could come back unhappy or in pain, and essentially the restoration is a lot more likely to fail. Another indication is how much the pulp bleeds. So if you have, for example, a trauma case and you have a pulpal exposure, if it's a very fresh trauma, very fresh pulpal exposure, and you're able to manage that bleeding, it might be just that the coronal portion of the pulp is inflamed, and a simple pulp cap and a dressing and restoring the tooth will suffice, and then you review it. But if you have a pulp that is bleeding and bleeding and bleeding and bleeding and you just can't get it to stop, I think you can, well, the guidelines say that you can confidently say that the radicular pulp is inflamed as well, and you need to look at doing some endodontic treatment on that tooth. Elective devitalization is something where you might not have signs and symptoms that indicate root canal in that sense, but you are going to be doing a treatment that requires the root canal to support a restoration. So this could be something like a post or core or an overdenture abutment. And the reason you're doing elective devitalization is basically you're going into that root canal system. So if you're preparing a post, you're drilling into the root, and the chance and the likelihood of not inviting, but the chance of bacteria contaminating that root canal and getting to the apical third when you're preparing for a post is huge. So you might put the post in, you might do a lovely post-core crown, but because you've introduced bacteria into that canal system, the patient might come back with periapical pathology, an infection, and things like that. So doing your root canal treatment first, putting a nice apical seal in there will minimize the risk of that happening and reduce the chance of failure of the restoration itself. So you've decided you want to do a root canal, and before you start a root canal, you have to take a PA. And a PA is going to show you a lot of information, not just on the estimated working length, but a lot of different things. So an examiner might ask you, well, what is a gold standard PA? Or you could be giving a radiographic report and might want to chuck this in. So a gold standard periapical, prior to RCT, you want to take a picture of the tooth in question. You want to make sure you've got the tooth from the cusp tip all the way down to the apex, so you can accurately work out the estimated working length. And you want to make sure that you've got 3 millimeters of bone apical to the root apices as well. So 3 millimeters of bone below where the root apex is, because this gives you enough tissue to be able to accurately see if there's any periapical pathology or not. So full tooth and 3 millimeters of bone apical, that's your gold standard. In terms of the things that you can see on this PA, it gives you a lot of information. It gives you information on, well, is the tooth restorable? Is it worth doing endo? So this is things like, well, what's the depth of the caries? How much of the tooth is left? Does it go subgingival? Does it go to the crestal bone? Do we have good periodontal support? So perhaps we want to be looking at things like bone levels. You're not going to be doing an endo on a tooth with 80% bone loss. It gives you information on the morphology that you're going to be working with. So the shape of the canals, the number of the canals. You want to be looking at, well, is the canal sclerosed? Can I actually get my file right the way down to the apical third of the tooth and effectively clean down there? Because if you can't, you might consider referral to a specialist opinion, or might not even consider root canal as a viable option. And it gives you information on the estimated working length when you actually go into the tooth. So it's a measurement from the cusp tip to the apex of the root, and then you subtract a millimeter, because this is about where the apical constriction should be. So this slide is called determining success, but I think in your exam, to stand out, it's really important to be thinking beyond dental school. Be thinking about things like valid consent, costs, timings, and how NHS dentistry essentially works. And I think it's really beneficial to pop this into your answers during your unseen case exams, and just show an examiner that you're thinking beyond the 5 years of BDS. So a good place to start is when you're doing endodontics, you need to look at the tooth as a whole, not just look at if you've got nice canals or not. And you need to be thinking about this from a perspective of how you're going to restore the tooth afterwards. How is this going to affect the patient in terms of times and costings? And it's really good to learn your NHS bandings, and I think if you can throw that in, that's absolutely massive. For example, we know that the literature tells us that if you do a root canal on a molar tooth and you do cuspal coverage, so like a crown, versus a direct restoration, it's 6 times more likely to succeed. We know that. But in the real world, that's not always what's best for a patient. Doing a root canal on a molar tooth, then doing a subsequent crown appointment, then a subsequent fit appointment, is quite time intensive and something that a patient might not be able to commit to. You also want to consider the fact that if you're doing a root canal and then a direct restoration on the NHS, that's band 2, so that's £65. But if you're doing a root canal and then a crown, because that involves lab work, it's then £282. In the real world, that's quite a big difference in price between the two, and something that you need to consider when you're giving your options to a patient. So I think a good way to answer a question is to say the gold standard would be RCT and a crown. However, I would consider the patient's time considerations and costings, because I know that in the NHS banding system, a crown is £282, whereas a direct restoration and an RCT is £65. It's just something that will help you stand out. In terms of determining success itself, the literature at the moment says that a primary RCT is about 85 to 95% successful, whereas a re-RCT is about 77 to 80% successful. But I think we all know that there are lots of different things that can affect the success and failure of an RCT. So I've popped them on the table here. Quite simple. Have a good look at those. And those are things to consider when you're treatment planning as well. I'm not going to go through this slide. The procedure itself is pretty self-explanatory, but but I've kind of highlighted the key points of the procedure here and why you do them. So yeah, feel free to pause and have a good look at this page. However, I am going to linger on this page because this is quite an important page, particularly in relation to your exam, and it's basically how can you assess the outcome of a root canal at the appointment, and how can you assess the outcome longer term in the future. So if we look at the immediate future, so assessing the outcome at the appointment, it's basically just the case of looking at a post-op PA. And you're looking at three different things basically. You're looking at your apical fill. So it's basically how far is the GP from the root apex. And if it's anything between 0 and 2 millimeters away, you say, great, that's a really nice apical fill. You then want to look at your obturation itself and the quality of that. And when you're looking at your obturation, you're looking at things like, is it well tapered? Is it well condensed? Is it free from voids? And have I seared the GP below the CEJ to leave enough room for a restoration? Then you look at the restoration itself and the coronal fill. And again, very simple. You want to look for things like, have I condensed and filled the whole of the pulp chamber? Is it well contoured? Are the margins nice? Are there no overhangs? Anything like that. Those are basically the things you're looking for at the appointment itself. When you think about long-term outcomes, when you do treatment on any tooth, you have a treatment plan for that tooth, and your treatment plan's always going to include a recall or a maintenance phase. And with endo, it's not just as simple as going, I'm going to check it at the 6-month routine recall and go from there. It's a good idea to have a justifiable time frame with a guideline to back it up. So the guideline that I use is the European Society of Endodontics, the ESE, and they basically do an assessment at 1 year, so a 1 year follow-up as a minimum, and they look at the clinical symptoms and they look at the radiographic presentation as well. Once you have these two, you then basically group it into favourable, unfavourable and uncertain, and you manage it accordingly based on one of those three categories. So the best case scenario is your patient comes back and their absence of pain, absence of symptoms, no swelling, no infection, and the tooth is functioning completely normal. Brilliant. Then you take a radiograph and you look at the tooth on the radiograph, and the periapical tissue is nicely healed and the PDL is normally formed. In this instance, you can say that it's been a favourable outcome, the root canal has been a success, and you don't need to do anything else, no further follow-up is required. If you have a patient that comes in and similarly, no pain, no symptoms, no swelling, no sinus, the tooth is functioning, but you take a PA and you can still see periapical pathology, and the periapical pathology is the same size or smaller than it was at the initial appointment, then you would consider this an uncertain outcome, because yes, there's been evidence of healing, but it's not fully healed yet, and you don't know if it's ever going to reach that stage. At this point, the ESE then says that you need to do a yearly follow-up clinically and radiographically every year for 4 years and determine if there are any changes. If the lesion heals, great, we can say it's a favourable outcome, it's been a good root canal. But if after 4 years the lesion persists, then it moves into the unfavourable outcome, and it basically means that it hasn't been a success. Other unfavourable outcomes are if a patient returns in pain or with any symptoms, swelling, sinus, things like that. Basically means the root canal hasn't worked. Or if you take a PA and at that 1 year PA the lesion has increased in size, you can say that again the root canal hasn't worked. If you have an unfavourable outcome, basically it means that you need to do something about it. You need to either re-root canal it, you need to refer to a specialist, or you need to extract the tooth. It basically means that the root canal hasn't worked and you've got to look at alternative options, or the risk is that that's just going to grow and grow and grow and continues to be an issue. So very straightforward. That's basically the guideline in a nutshell. I'd recommend you have a read. European Society of Endodontics. It's a really nice way to classify and justify endodontic follow-up in the future. So just to round endo off, I'm basically just going to quickly touch on surgical endodontics. You might be asked things like, what are your indications and what are the types of procedure that we can do? In terms of indications, it's kind of just basically where you can't access the canal or the apex through conventional means, so you can't access it through an access cavity. So indications are things like you've got a perforation where you can't reach it conventionally, you've got extruded material through the apex, or you've got apical pathology, but again you can't get there through the access cavity, or you have a failing endo where you need to do a re-RCT, but you can't access it through the through the access cavity. So if you're thinking access cavities and you can't get in there, surgical endo is probably the way you're going to go. And in a nutshell, the types of procedures you can do are things like incision and drainage. So this is basically where you take a scalpel, say you have a large swelling, you literally cut the tissue and drain the pus and the infection that way. You could do something called an apicectomy and curettage, and this is basically where you raise a flap and you section the apex of the root, which is commonly the most infected part, and then suture the flap back together. Or you can do something like called a root hemisection, which I don't know if it gets done often. I saw it once at uni and I had absolutely no idea why there was a molar with one root. But essentially what they do is, if it's a root that has one root that has pathology and the other root is okay, the surgeon will quite simply hemisection that tooth, get rid of the root, but leave the other root in situ and the crown functioning. So yeah, that's it in a nutshell. That's endodontics covered, I hope in enough detail. And now it's time to chat about all things gums. So perio shouldn't really be that difficult. Generally, it's quite straightforward. You have risk factors. If you control them, fine. If you don't, you start to get gum disease. If you don't control them further, then your teeth start to fall out. It's pretty simple, to be honest. But it can get quite confusing because they bring out lots of new guidelines. The guidelines are full of loads of different colours, loads of weird new words, and loads of information on a sheet of paper. So what I'll do is I'll base this part of the presentation basically on the Good Practitioner's Guideline, which is the book you can see on the screen now. And I'll also base it on the new guidelines, so the 2019 interpretation of the 2017 guidelines. And I'll give reference to the old guidelines throughout, just to try and kind of keep a clarity and make it a little bit easier for you guys to digest and understand going forwards. So let's talk risk factors, and these have been taken from lectures, personal experience, and also from the Good Practitioner's Guide. And they're basically things that put a patient at a higher risk of developing gum disease and the reason why this might happen. So the first and the most obvious are your plaque retentive factors and your oral hygiene. Poor oral hygiene, we know that if you don't brush your teeth, a biofilm can form, and the biofilm is basically bacteria, food debris, and plaque, and the bacteria releases lots of inflammatory markers, lots of acids. What they do over time, this inflammation can can cause inflammation to start with, and then can break down the junctional epithelium and cause clinical attachment loss and bone loss, and degradation of the periodontal tissues. So keeping your mouth clean is fundamental. If you don't, you're at high risk of periodontal disease. And plaque retentive factors kind of work in a similar way. Basically what they mean is it's a place where bacteria likes to stick onto and live that's perhaps a little bit harder to clean, so it acts as a reservoir for this bacteria. So plaque retentive factors, we're talking about things like calculus, overhanging restorations, so restorations that aren't contoured nicely, that don't have good margins, and rutifications, all places that bacteria can sneakily live and sneakily thrive. Other risk factors, you can see there are a ton of them on the page. So we've got things like an increased age, and this is basically where a patient's immune system drops and they have a reduced capacity to fight off bacterial infection, so they're more susceptible to perio. A patient who's older might also have a reduced salivary flow or might be on multiple medications that cause xerostomia. In this instance, if you have less saliva, less buffering, less mechanical clearance of the bacteria, and ultimately you have increased risk of perio. Dentures is another thing, very simple, very relatable. Not very relatable, very simple and related to plaque retentive factors. Dentures are a great reservoir for bacteria. If bacteria is there on the denture, you know, day in, day out, you're more likely to have periodontal disease and gum disease. Stress is a big risk factor. Basically, what stress does is it acts as an immunosuppressant. So if someone is stressed, they have a high cortisol release and an impaired wound healing and an impaired ability to fight off bacteria. And someone who's stressed might also slightly neglect their oral hygiene. So someone who is stressed or rushed might brush their teeth for a little bit less, might not clean in between their teeth as much as is considered the gold standard. Smoking is massive. We know a lot about smoking and why it inhibits or why it causes gum disease. One of the main factors is the fact that in a patient that smokes, the microvasculature around the gums tends to die off. So if you have someone who smokes and you're probing with a BPE probe, quite often they won't bleed even if you expect them to. And this is basically because the little vessels by the gums have basically died off. And when this happens, again, you get less nutrients. I hate using that word, but less nutrients to the gums, reduced blood flow, less healing, and things like that. Pregnancy is a big one. Any patient that presents who is pregnant, you also have to do a really good, thorough gum exam, and you also have to make the patient more aware that during pregnancy, the hormonal changes puts them at a higher risk of gum disease. So you have to make them aware of that and have to monitor that carefully. Diabetes, we know, has a huge bidirectional relationship with gum disease. There's so much evidence now that show that one affects the other, and conversely as well. So in a patient that has diabetes, poorly controlled diabetes, they're much more likely to have unstable periodontal disease. And it works the other way as well. So in a patient that has unstable periodontal disease, they're much more likely to have uncontrolled diabetes and elevated blood glucose. And basically the reason in a nutshell is because both diabetes and periodontal disease are inflammatory diseases, and the mouth is not a separate entity to the body. So when you have these release of these inflammatory markers and these molecules of inflammation, it affects the body elsewhere. Diabetes also has effects on a patient's ability to heal after injury. So limited wound healing, immunocompromised, all of these things, these general things that kind of are linked in a lot of the risk factors are present in diabetes as well. And then the last two are ones from the Good Practitioners Guidelines. So medication-induced gingival enlargement is basically where you have a patient who has been taking a certain medication for a long time, and some medications can cause the gingiva to overgrow slightly. When the gingiva overgrows, it can be difficult to clean with a TP or underneath the gum, and bacteria again can live in there and it can put the patient at risk of gum disease. So some medications that can cause this are things like calcium channel blockers like amlodipine or nifedipine. You can have things like anticonvulsants, like, for example, phenytoin, and you can have also immunomodulators like cyclosporin. They're kind of the classical three groups that cause it. So something, if you see that in a patient history, you have to just be aware of that. And I've left genetics in the corner at the bottom because you'll get a lot of patients in your career. I found it so much during my foundation year, and even at university, where patients come in and they've got gum disease and they will simply blame it on genetics. And yes, people can be more susceptible to gum disease. You can have patients that are more sensitive to inflammation and perhaps their attachment loss is at a greater rate than somebody else. But it's not the be-all and end-all. There are so many modifiable risk factors that someone needs to control or someone may not be aware of. And it's not the fact that one thing will cause it and one thing won't. A lot of patients will have plenty of these risk factors that need to be identified and need to be managed accordingly. So guidelines, this is where things can start to get a little bit confusing. So let's break down the old guidelines, the new guidelines, and kind of the things that you need to know for your exams. So these are the BPE guidelines, and they haven't really changed. Everybody should know how to do a BPE and why a BPE is done. And the best place to get your concrete guidelines are from the BSP Good Practitioner's Guide. So the page that I had on the screen a couple of slides ago. And it basically has a table of why you do a BPE, when you do a BPE, how you do a BPE, and then what you do in relation to the scores. So I'm not going to run through the table. It's something for you to look at in your own time. But basically, these are the scores on a BPE, 0, 1, 2, 3, 4, and a star for furcation. Basically what it indicates and how you manage that accordingly. A BPE is a screening tool. You don't use it to diagnose. So you use it as a rapid kind of assessment of the gum health, and then use it to do your further investigations after that to get to your diagnosis. And one of these diagnostic tools will be your 6PPC, which essentially is a more accurate BPE. A BPE, you walk it around the sulcus and you use a Hu probe. And a Hu probe has quite thick black bands, whereas a 6PPC is done at 6 points around the tooth with a Williams probe. That is marked at 1 millimeter increments, so you can get an accurate measurement of the pocket depth at 6 points around the tooth. Then you can make a diagnosis from that. And the type of things that you're looking at on a 6PPC, so first thing is your periodontal pocket depth, so how deep is a pocket. Anything that's up to 3 millimeters is considered clinically healthy. Anything that is 4 millimeters or more is considered to have some attachment loss. You can also do a BP, whilst you're doing your 6PPC, you can look at your mobility. So do we have any teeth that are rocking? Mobility is assessed on grades 1, 2, and 3, with a grade 1 being 1 millimeter horizontal movement of a tooth. A grade 2 is 1 to 2 millimeters of horizontal movement, or a grade 3 is anything that is 3 millimeters or greater horizontally, or you might have some vertical movement on a tooth. You can do your 6PPC to assess bleeding on probing, and essentially what this is when you're doing your 6PPC, do you have any points at which there is bleeding at the gingival margin? And essentially what that means is it means there is inflammation at the base of that pocket, and it basically means that there is active bacteria and active gum disease in that area. So if you do a 6PPC and then you do some management and you do the 6PPC again, if you see a reduction in the bleeding score, then you can say that the periodontal disease is more stable and there's less active gum disease at the moment. So it's a very quick tool, but very easy to record and very useful as well. Fourth thing you can look at is you can look at furcation. So like I said earlier, it's a plaque retentive factor and it puts the patient at a higher risk of periodontal disease worsening. So you can grade your furcations as well, and instead of using your Williams probe, you use something called a neighbour's probe, and you basically just pop it through the furcation and see how much bone loss there is in that furcation area. So we do this similarly to mobility. We grade this from 1, 2, and 3. So a grade 1 is where your neighbour's probe goes less than 3 millimeters kind of horizontally through the furcation. A grade 2 is if it goes greater than 3 millimeters, but you can't get it the whole way through. And a grade 3 is where your neighbour's probe goes completely through, so you've got 100% bone loss in the furcation area, basically. Finally, you can monitor recession. Recession is, you want to monitor it because obviously you can have, if you have root exposure, you have an increased risk of root caries, poor aesthetics, and things like that. And for recession, we tend to use the Miller's classification, which you can see a picture of here, which basically describes the degree and the severity of recession itself. So that's a really good thing if you've never seen that before, just to quickly learn, because when you're doing particularly a periodontal unseen case, you throw in the Miller's classification and it's a little cheeky few extra bonus points, just to show the examiner you know what you're talking about as well. So another really good tool for classifying perio is radiographs. And unfortunately, the guidelines are a little bit unusual. They probably differ from the things you're used to doing. But as a gold standard exam answer, you always need to refer to the FGDP guidelines. And if you don't know what I'm talking about why they're a little bit unusual, perhaps you haven't read them, it'll become a little bit clearer in the next minute or so. So basically, when you do a radiograph, you are in perio, you are doing it for a number of reasons. The first and probably the most important reason is you're doing it to assess the bone levels, and you need to do the bone levels based on the new classification. You need to find the most severe site of bone loss, and you can use that to work out your staging and grading. So that's the initial reason you do it. You'll also do it to look for things like intrabony defects, furcation involvement, subgingival calculus, overhanging restorations, poor margins, and any pathology. And you can use it to assess for restorability as well. So there's a whole host of reasons you might take a radiograph. And you think you would just take PAs because that, to me, that makes logical sense. But unfortunately, the guidelines differ slightly to that. Even though I don't ever take any of these x-rays that they recommend, I just take PAs. When I was answering my exam, I mentioned these because that's your gold standard, basically. And I quoted the FGDP guidelines. So this is from the document, the selection criteria for dental radiography. Have a look at that if you haven't. It's a really good guideline for not just perio, but for radiographs for everything. And it basically categorizes what radiographs you need to take dependent on the scores you get in your BPE. So if you see the box on the left, this is for a patient who has more mild pocketing. So we're talking about pockets of 4 and 5 millimeters, which is basically a code 3 on your BPE. And if you have this, the FGDP suggests that you take horizontal bite wings and take intraoral periapicals if it will help or if it will add any more information, it will give any more information. And I argue that horizontal bite wings are not that useful because you can't calculate bone loss as a percentage based on a horizontal bite wing because you're not going to see the apex of the tooth. Yes, the justification is there because with a code 3, you know that you're not going to have bone loss to the apex. But if you're trying to stage and grade your periodontal disease, a horizontal bite wing is not going to be satisfactory. You need to see the whole length of the root to be able to calculate it as a percentage. But like I said, it has to be a gold standard answer. So if you have that and you're answering a question, I would say I would consider taking horizontal bite wings according to the FGDP guidelines. But if I was to calculate the stage and grade, then I would consider taking supplementary PAs as well, so that I can see the complete length of the root and calculate the percentage of bone loss. That's kind of your gold standard answer. If you have larger pockets, so 6 and above, so anything that's a code 4 or more on a BPE, so we're thinking more towards much more clinical attachment loss, then we still don't say, the FGDP still doesn't say PAs as your gold standard. It says vertical bite wings, which, again, never in my life have I taken them. And again, it says supplement them with intraoral periapicals if needed, if it's going to change the management or if it's going to give you any more information. And again, I argue that you need to see the apex of the bone. You need to calculate the percentage bone loss. So as for a code 3, your gold standard answer would be, according to FGDP guidelines, I would take vertical bite wings for X, Y, and Z. And I would consider periapicals of the most severe sites of bone loss to calculate the stage and grade based on the new periodontal guidelines. Something like that. In the bottom box, it kind of gives you a little bit more information on why you take it and if you need to take an OPG or not. So it kind of, in a nutshell, it says that you can assess the whole dentition to an optimal standard if you have a good OPG, and use supplementary PAs as well. So if you have a patient with scores of 4 all over, then you're well within your right, according to FGDP, to take an OPG to try and ascertain where the bone levels are, essentially. Right, let's tackle these guidelines. And I've thrown in the old guidelines from the 1999 classification because this is what I learned in years 1, 2 and 3 at uni before they shifted us over to the new guidelines. So it's nice to have an understanding of these if you haven't seen them before. And basically what the BSP did previously is they categorized gum disease on the site. So was it localized or generalized? And then the severity was given based on the amount of pocket depth you had. And then they would categorize it into chronic, aggressive and systemic based on how long you've had it. So if you had a patient who had 4s in all quadrants that affected more than 30% of the teeth, and they had pockets of 7s and 8s, and they'd had perio for 25 years, it would be generalized severe periodontitis, chronic generalized severe periodontitis, something like that. So you don't need to know it inside and out, it's just nice to have an awareness of it. And this is our nice new colourful guideline, which the BSP published in 2019, but it's actually the implementation of, it's called the implementation of the 2017 classification. So try not to get confused between the two. Basically what it is globally they produced these guidelines in 2017, and the British Society of Periodontology basically took those, reviewed those and published a kind of amended version of those for use in this country in 2019. So whenever you quote it, you quote that it's the 2019 BSP guidelines, not the 2017, it's from the 2017 global ones. And it can look difficult at the start because there's a lot of colours, there's a lot of words, but I think it's quite straightforward to use, and once you've practiced it a few times, it's quite nice, it's quite self-explanatory, and it's quite easy. So what it does is it basically takes codes 0, 1, 2, 3 and 4, and then it uses those to tell you a management strategy and also how to get a diagnosis. So when we're talking about codes 0, 1 and 2, we're basically talking about anything that on a WHO probe is less than the first black line. So no clinical attachment loss, and we're in the realms of gingivitis. And the way you diagnose gingivitis is essentially you do it on location. So if you have less than 30% of teeth, you have localized gingivitis. If you have more than 30% of teeth, then you have generalized gingivitis. It's very straightforward like that. When you have a code 3, you're kind of in that murky area between, is it still gingivitis or is it periodontitis? Because a code 3 is when on the WHO probe, the first black band, you're kind of in that zone, but you're not above it. So a code 3 could be due to inflammation, and inflammation could die down and you could have no clinical attachment loss, or it could be the start of some early periodontitis. So with a code 3, you don't initially diagnose it. The way that the BSP says to manage it is you do your radiographs and you do your kind of your therapy. Then you reassess it in 3 months' time with a 6 ppc. If the pocket is less than 4 millimeters, you treat it as if it's a code 0, 1 and 2, so gingivitis. If it's more than 4 millimeters, then you move it onto the code 4 and you diagnose it in that manner afterwards. In terms of a code 4, we are now talking about periodontitis. So we're now talking that we've got clinical attachment loss, there's been inflammation, there's bone loss, and we have quite a deep pocket. And this is where things start to get a little bit confusing for people, but they don't need to be. So the way that it works is you have the area, so is it localized, is it generalized, or is it just the molars and incisors? And then you need to stage and grade the teeth, which are two completely new words. So it's understandable that people can find it quite difficult, but they're very easy to work out. So with respect to the location, it's very similar to gingivitis. So if you have more than 30% of teeth, you have generalized periodontitis. If you have less than 30% of teeth, you have localized periodontitis. If you have it just confined to the incisors and the molars, then they call that molar incisal pattern. So much like your endodontic diagnosis that we spoke about earlier, they're going to be broken down into 3 stages, and then we're going to wedge them all together with an example. And next we have to do our staging. And essentially staging is where is the worst site of bone loss on an x-ray. And it's really simple. You stage it in 1, 2, 3, and 4, and it basically tells you the severity of the periodontitis. So if you have a periapical, you know that the bone should pretty much be at the CEJ in a normal patient, in a normal healthy patient. You basically look and say, is there less than 15% bone loss? Is there bone loss to the coronal third of root, the mid third of the root, or the apical third of the root? And it's your own clinical judgment, and you stage and grade it that way. So if you have less than 15%, it's stage 1, very mild. If you have bone loss to the coronal third at its worst, then it's stage 2. If you have it to the mid third, then it's stage 3. And if you have it to the apical third, then it's stage 4, and it's the most severe. Very straightforward. So you have your location, say localized, generalized, and then you have your staging. Next thing is you need to work out your grading. And grading basically is what is the rate of bone loss. So to work out the grading, you essentially need to work out the percentage of bone loss. So how much is gone as a percentage of the maximum amount, and then you divide that by the patient's age. And the number that it gives you basically gives you the grade, and again, it's the rate of progression. So if the answer you have is less than 0.5, then it's a slowly progressing disease and it's stage A. If you grade A, sorry. If you have 0.5 to 1, then it's a grade B, and if you have 1 or more, then it's a grade C, and it's a rapidly progressing disease. So again, very straightforward. For example, if you have bone to the mid third of the root and it's 50% of the bone loss, you just divide it by the age, and whatever number you have, you put it into the grade. Lots of practice, and you'll get the hang of it. So we do location, we do stage, we do grade, and then after that we basically just have to comment on whether it is stable or unstable or in remission, and then we just have to give a risk factor assessment. Put it all together, and then we have our overall diagnosis at the end. So let's run through an example and try and show you that it's actually quite simple to use, and just basically that practice makes it. So let's run through an example quickly, and I'll basically show you that it's actually really straightforward to use. And once you've got the hang of it and had a little bit of practice, you'll fly through it in no time. So we've got a little bit of information, and we've got a PA of the lower right quadrant, because apparently every PA I include is lower right. And we're basically going to split it up into 6 chunks. We're going to wedge it all back together and get a nice diagnosis. So the first thing we've got to look at is our location, and we can see on the purple box on the left that we are affecting 65% of the teeth. So if we refer back to the guidelines, they say that anything that affects more than 30% of the teeth is considered generalized. So stage 1 is, well, I won't say stage, actually that will confuse things. The first part of our diagnosis, generalized periodontitis. Then we have to look at the stage, which if you remember from the slides previously, essentially is where is the most severe point of bone loss in relation to into the root. And I'm looking at it's easy to look at the mesial of the lower right 7 because that's the biggest tooth and probably the biggest gap. But I'm probably considering the distal of the lower right 6. And you can argue that it's at the apical or the mid third, but I've put it at the mid third just for the sake of the presentation. So because it's at the mid third of the root, as our example, it's stage 3. So we've got generalized periodontitis, stage 3 so far. Next thing we're looking at is the grade. So what's our rate of progression? Well, we've got a 55-year-old patient, and we can work out, it's kind of your best guess is what is the amount of bone loss. For the sake of argument, I've said that we've got 60% bone loss in a 55-year-old patient. So if you do 60 divided by 55, you get greater than 1. And according to the new guidelines, greater than 1 means you've got a grade C. So far, generalized periodontitis, stage 3, grade C. Very straightforward. Then you need to comment on your stability. So in terms of stability, if you refer back to the guidelines, we're looking at things like bleeding on probing and the greatest pocket depth. Well, we've been given information that the deepest pocket is a 7 millimeters. So this is considered unstable. And risk factors that we've got of this patient is that they're a smoker. So if we put it all together, diagnosis for this tooth, generalized periodontitis, stage 3, grade C, currently unstable. Risk factors include that the patient smokes 20 cigarettes a day. It seems quite long-winded because I was explaining it all, but if you were to look at that PA, you could get the diagnosis in 15 to 20 seconds once you've practiced it a few times, so don't be too concerned about that. Cool, so we've got our diagnosis. Now it's basically how do we manage the case. And unfortunately, the BSP decided to change a lot of the lingo in 2020, get rid of the really simple words like scale and polish, root surface debridement, things like that, and replace them with new funky words like PMPR, which is professional mechanical plaque removal, which is a lot more complicated. So I've just included their table here, basically with the historical terms and the new terminology that's been included, just so we're all kind of on the same wavelength when I'm saying different things throughout, and not for you to think that I'm neglecting words like subgingival scaling and things like that. And what the BSP done in terms of management is they've basically outlined in steps how you manage patients with periodontal disease. And again, it seems like there's a lot of colour and a lot of words, but once you kind of digest it and have a read through it, it's not actually as complicated as it looks. And essentially it's in relation to what disease the patient has and how you manage it. And you always start at step one, and step one is basically, in a nutshell, it's things like your oral hygiene, explaining the risk factors, doing PMPR, which replaces your scale and polish, and then having a recall. If a patient shows improvement and they show that they're motivated, then you move them on to step two. If a patient's not engaging, essentially you just continue to repeat step one until they start engaging and move on to step two. So I'm not really going to go in any real more detail than that. It's probably a lot easier if you have a read through that yourself. But we will go through the basics of kind of what you should be doing in stage one on the next couple of slides. So in terms of your kind of your step one protocol, these should be your bread and butter really. They're very straightforward. Things you will have been doing in dental school since the very beginning, and it's basically just your preventative measures that you should be doing day in, day out, and should be seamless at. So in terms of controlling risk factors, these include things like oral hygiene and diet instruction, and you want to be quoting things like delivering better oral health toolkit and basically how to brush based on that. You can be doing things like plaque and bleeding to use that as a visual aid for the patient, to show them where they're missing, and also use it as a motivational tool and say, well, we want to try and get below 20% plaque so we can move the treatment forwards. PMPR, like I previously discussed, is basically just a fancy new word for scaling. So it just is removing calculus and things like that. Controlling risk factors also includes things like removal of plaque retentive factors, so polishing overhanging restorations, replacing restorations if they're needed, denture hygiene instruction, just things like that. I've written oral hygiene and diet instruction twice. Don't know why, but basically it's super important, but I'm sure you know that already. And then something else that's a little bit extra is you can consider liaising with the GP. So for example, if the patient's got uncontrolled diabetes, you can refer them for blood tests, or say, is there a way, refer them to the GP to discuss their diabetes, explain the bidirectional relationship, and just try and get alternative factors under control, basically. In terms of things you can use alongside these, which are your bread and butter, chlorhexidine mouthwash is brilliant. It's an antibacterial mouthwash that is useful alongside. I recommend it to my patients for a maximum of 7 days, and I tell them that there are risks that it might make your taste slightly funny temporarily, and there's a risk that you can get tooth staining, so that's why we only recommend it for 7 days, and we only recommend it when the dentist prescribes it as well. In terms of antibiotics, they're not something that we really need to be considered with. As a general dentist, it's not something that we're going to prescribe. It's someone in secondary care who's a periodontal specialist that they may consider. But it's good to understand that you can have local and systemic antibiotics as an adjunct to perio if needed. And then Our review. So we've done absolutely everything. We've controlled our risk factors, given them the best scale and polish, or PMPR, of their life. And when do we review? Typically, it's around 6 to 8 weeks. It can be anything up to 12 weeks. And basically, it's enough time for the gingiva to heal and to give the chance for the long junctional epithelium to heal, the gum to recede a little bit, and things to slightly stabilize. So like endo, just to finish, I'm going to briefly touch upon periodontal surgery. It's not something you need to know inside and out, but you basically need to know the indications for referral and what a periodontal specialist might do. So according to the NHS, you've got a few indications for referral, and the most common one is someone who has sustained gum disease, someone who has non-responsive periodontal disease in an otherwise cooperative patient. So it's someone who's got pocket depths of 6 or more millimeters that have had multiple rounds of non-surgical therapy, so risk factor control and things like that. And they've shown good cooperation, so they've got good oral hygiene and they've got really low plaque scores, but for some reason or another, they're just not improving and they need a little bit more specialist help. Another indication is something called ANUG or ANUP, which essentially is a bacterial infection, acute necrotizing ulcerative gingivitis, or acute necrotizing ulcerative periodontitis as well. The types of things that periodontists are going to do, they've got a number of options, and it basically depends on what the bony defects are and what the degree of periodontitis is as well. So just to run through 3 kind of more common ones. The first one is resective surgery. And basically what resective surgery is you recontour the bone and the gum to make it a lot easier for the patient to clean. So you often sacrifice aesthetics for health. So more often than not, there'll be considerable recession at the expense of the pocket depth. So if you have a pocket of 8 millimeters, you can kind of recontour that gingiva, pull it down the root so that the pocket's only 3 millimeters, but the root is exposed. And it just makes it a lot easier for a patient to keep it clean. And although it doesn't look as good, at the end of the day, if the patient's going to keep that tooth with periodontal disease, the likelihood is that they'll lose it at some point rather than keep it. The next one is regenerative surgery, and this is kind of using biomaterials to rebuild the tissue. So these are things like guided tissue regeneration, bone grafts, enamel matrices, and things like that. It's basically you just try and encourage the hard and soft tissue to reform, so bony formation and soft tissue formation as well. Finally, if you have furcations but not really pocket depths and things like that, so furcations that act as a plaque trap, you can do something called tunneling. And essentially what it is where you have your furcation, you recontour it and make it really easy to clean, so the patient can get a TP the whole way through, can get their toothbrush nicely around there, and basically just make it less of a plaque retentive factor and less of an area that's gonna catch bacteria and exacerbate the periodontal disease. And finally, prognosis. I've just chucked this in because it's good to have an understanding of the prognosis in gum disease. So this little table here is something to look at nicely and just give a good classification of what the prognosis in that condition is. And that's it. And that kind of rounds up perio, and we'll move on to our unseen case now. So if you haven't already done the oral surgery video, basically what the unseen case is it's a case that I have collated from my foundation year in relation to the topics that we've just studied, and I give you a certain amount of time to look over it, and then there's questions that you can answer out loud at the end. And it's an invaluable tool to practice with. Basically, you learn so much from being in a time pressured situation, writing down lots of notes, and then trying to articulate an answer to a question. It's a really good way to identify strengths and weaknesses, so what you're really good at, or perhaps things that you've missed at. So when I give my answers, you can make a comparison between the two. And yeah, basically just write down your learning needs and things that you need to improve on as well. So we will move on to the rules, and essentially these are to make it as realistic as possible. So it's nice to do it in an exam setting. So essentially what we'll do is it's a closed book kind of exercise, and you have one sheet of A4 paper in front of you that you can make notes with. Set yourself a 10-minute timer, and then on the following slides there'll be information and a case. And what you want to do basically is you want to flick through those stills as it's paused, make notes on your A4 paper. Once the timer's up, on the following slides there'll be questions, and then answer those out loud. As soon as you're finished with those, my ugly face will pop back on, and then I'll answer the questions, and you can basically compare the things that you said to the answers that I've given as well. And yeah, it's really good. And if you want to, message me on Instagram, feel free to message me any video answers, things like that, and I'll have a listen and give you nice feedback as well. So, good luck. 10-minute timer's on, and we'll start the case now. Hey guys, so hopefully you found that useful, hopefully you found it a good exercise. It's not too challenging, the questions, they're fairly straightforward, and I think the take-home message is that these are just an example of the things that you might be asked. An examiner is not there to trip you up, they're not there to try and make you fail, they're not there to really catch you out. The things that they want to see is that you are safe, you have a basic understanding of the knowledge and can apply that to a case. So the majority of the marks that you're going to get during your Q&A in an unseen case are basically from the simple stuff. If you show the examiner that you can smash the basics, then they're going to start to ask you the distinction level questions. So it's really good to practice the fundamentals, pick out the key points and answer the straightforward questions very concisely and very quickly, and try and take yourself to those distinction answer questions at the end. So without further ado, let's move on to the question and answers, and we'll start with question number 1, which was basically giving a brief description of the history and the case. And like I said in my oral surgery video, you're going to want to do this in about 30 to 45 seconds, and you basically just need to summarize what you've seen and what you've written down on your paper. So the kind of things that I would say for this case, I would say something like, there's a 27-year-old female that came in for a routine checkup. She complained of a spontaneous dull aching pain in the upper left quadrant that started in December. She has a pain when she's biting. It keeps her awake at night. It's not affected by hot and cold, and there are no other associated symptoms. Medically, she suffers from asthma and takes a Ventolin and Clinil Modulite inhaler. She suffers from depression and takes citalopram. The patient doesn't have any drug allergies. Socially, she smokes 10 per day, but we have no information on how long for, and she drinks 8 units of alcohol per week. Past dental history, she's an infrequent attender, and that's the only information we have. In terms of the examination, intraorally and extraorally, there are no abnormalities detected. And when the teeth were investigated, again, no abnormalities were seen. The BPE scores were 1s and 2s throughout the arches. So it's quite concise, it's quite quick. The examiner's going to know the case you have in front of you. I have no idea how long that took me. I hope it's somewhere between 30 and 45 seconds. But they'll have seen the case and they just want to know that you can pick out the key points and summarize them efficiently, basically. So with question 2, it is basically, you just want to round off the histories that you've got. So your history of presenting complaint, medical, social, and past dental history, and just build a complete picture. So the kind of things that you would ask in relation to the HPC is, if you don't have a complete Socrates, you might ask just the missing questions there, just to build a better picture of the complaint itself. In regards to the medical history, you should be thinking about picking out additional questions in relation to key factors. So things like, in this case, the patient has asthma, and asthma is very relevant in the dental setting. When you think about asthma, you should start thinking about medical emergencies, and you should also start thinking about the fact that some high fluoride toothpaste and some fluoride varnishes contain colophony, and colophony can trigger asthma attacks and is contraindicated in people with severe asthma. So the kind of things that I would be asking in this case is it well controlled? Is it uncontrolled? Have you ever had a severe asthma attack? Have you ever been hospitalized? If the patient says yes, then I would find out information on when they were last had a severe asthma attack, what the kind of triggers are, and what the signs and symptoms that I need to look out for if a patient has. And if a patient discloses something like this, straight away I'm discussing with my nurse. I'm saying let's get the medical emergency kit, just in the case that something happened. So that's one of the things you want to pick up on. Another thing in relation to asthma is the patient's taking a steroid inhaler. They're taking their clenomodulite. Obviously, an inhaled corticosteroid taken daily puts the patient at a high risk of fungal infections. So that's something that I need to be aware of when I am doing my examinations and things. In terms of the social history, we've got information on the fact that the patient smokes, but we don't have any information on how long for, so we can't really calculate pack years and things like that. We don't have any information on their employment or their stress levels, which affect things like compliance and periodontal disease risk and things like that. And we have absolutely no information on how the patient brushes, which as dentists is a fundamental thing that we need to be able to understand. So we need to have good information on their oral hygiene regime and their diet analysis as well. And perhaps if it's appropriate, we can ask the patient about their mood. So the patients disclose that they suffer from depression and takes citalopram. Patients who have depression often can neglect their oral hygiene as a not a side effect, but it's a consequence of having low mood and depression. So sometimes it's appropriate to broach this with the patient and say, how are you doing at the moment? Do you feel like it affects the way you keep up with your oral hygiene regime and things like that? So an intraoral soft tissue exam in this case is really important because the patient smokes and the patient drinks alcohol, and together that puts them at quite an increased risk of oral cancer. So we need to be checking all the soft tissues for lumps, bumps, any discrepancies, any abnormalities, and things like that. So with the radiographic report, I'm not going to do it for all three. I'm just going to do it for the PA, show you guys how I structure it, and then from there it's pretty self-explanatory, and you can apply that to the bite wings. So the kind of things I would say is something like, we've got a PA of the upper left quadrant. It's diagnostically acceptable. We've got the tooth in question in full, which is the upper left 5. We can see from the cusp tip to the apex with at least 3 millimeters of bone apically, which is your gold standard PA. We've got no evidence of bone loss. Teeth present, we've got the upper left 3, 4, 5, 6, 7, 8. There are radio opacities in the distal coronal part of the upper left 5, mesial and distal coronal part of the upper left 6, and mesial and distal part of the coronal part of the upper left 7. In terms of radiolucencies, there's a distal occlusal radiolucency of the upper left 5 that's into the pulp. There is a periapical radiolucency associated with the upper left 5, and there is also possibly a mesial radiolucency associated with the upper left 8. In terms of the upper left 8, it's one of those things where it's quite ambiguous. It may or may not be caries, but anything that you see that you think may or may not be caries, you have to disclose to the examiner. Even if it's glaringly obvious, like the upper left 5, you have to say it, because if you don't say it, then they will just assume that you've missed it, and as an examiner, that will basically tell them that you're unsafe, and it's a massive red flag. So even if you see something like this upper left 8, just say there's a possible radiolucency in the upper left 8. I'd have a real thorough clinical examination just to determine if it's pathology or not, or I might take an alternative x-ray like a bite wing to see if I can visualize it and confirm that it's a radiolucency or not. Something like that shows you're thinking ahead and haven't just disregarded it basically. So other special investigations that have been missed out, well, there's quite a few, and there's quite a few that we spoke about during the presentation. These are things like percussion, tooth sleuth, sensibility testing, and then things like diet analysis and plaque and bleeding, which also come under sensibility testing. You can basically throw any in there, but I guess these are kind of the main ones that you'd be looking to do. So with question 6, we now have a little bit more information and a few extra special investigations in relation to the tooth. And using our diagnostic, kind of split it into 3 and pack it all together from earlier, I think we can come up with a nice diagnosis for the tooth. But we also have to remember that this question doesn't say diagnosis for the tooth, it says diagnoses in the case. So you also have to mention any other pathology that you've seen before. So my first diagnosis is generalized gingivitis. We've got BPEs with 1s and 2s and I think 1-0. So the patient is suffering from gingivitis, and that is a diagnosis that you should never miss out. Based on the radiographs, I think we have enamel caries in the lower right 8 mesial, lower right 7 mesial and distal, lower right 6 distal, upper left 8 mesial, lower left 8 mesial, lower left 7 distal. You note that I've noted to what portion of the tooth it is in, so enamel, and then the surfaces that are affected as well. In terms of the upper right 7, I've noted that there is mesial occlusal caries into the outer 2/3 of dentine. So again, the tooth, the site, and how far into the dentine it extends. And then in relation to our tooth in question, I've put upper left 5 distal occlusal caries into pulp, symptomatic irreversible pulpitis, and symptomatic apical periodontitis. So upper left 5 distal occlusal caries into pulp, that's evident radiographically. Symptomatic irreversible pulpitis because the patient is having pain that's keeping them awake at night. It's positive to endofrost, but it's dull and aching afterwards. So it's not your reversible pulpitis, which is a sharpness, it's your irreversible pulpitis. And then in terms of symptomatic apical periodontitis, well, the tooth is tender to percussion, it's painful when you're biting down, and there is evidence on the PA of an apical radiolucency. So we've got those 3 portions, we've put them together, and we've got a real complete diagnosis for the case and for the tooth itself. So in terms of restorability and prognosis, we don't really have kind of clinical pictures to see actually how much tooth tissue and things like that are left. So this question is all about thinking logically and then just giving, kind of a distinct and accurate kind of estimation or guess on the prognosis of the teeth. So the way that I look at it is I break it down into sections. So the first thing I'm thinking about is, well, what's the prognosis of the teeth with enamel caries? And when we talk about prognosis, which I spoke about in one of the videos before, prognosis you look at from 3 aspects. You look at it from a periodontal aspect, so are there good bone levels? Is it good oral hygiene? Are there any deep pockets? You look at it from a tooth tissue perspective, so how much tooth have you got to restore? Have you got significant tooth loss? Is it subgingival or supragingival margins? Have you got a ferrule if you're doing an indirect restoration? And finally, you look at it from an endodontic perspective. So is there any periapical pathology? What size is the periapical pathology? Is there a swelling? Is there a sinus associated? If we're thinking about doing endo, can we see the canals? Are they sclerosed? Is there a funny morphology? Just things like that that will affect your treatment outcomes. So in terms of the enamel caries, we should be looking at the enamel caries from a point of everything. So we can see on the bite wings that we've got good bone levels. BPEs tell us that we haven't got any deep pocketing. So generally we know that the periodontal prognosis for all the teeth is going to be good. Enamel caries are reversible. We should be thinking that we don't need to intervene with a drill. Anything that hasn't breached the dentine has the potential to remineralize. So with good oral hygiene and a high fluoride intake, we should be able to address these without kind of drilling into the teeth. So from an enamel caries perspective, I would say that all of the teeth with enamel caries have a good prognosis, providing that the patient is compliant with the treatment plan. In terms of the upper right 7, again, let's look at it from the 3 aspects. We know we've got good periodontal support, good bone levels, and there's no deep pocketing. We can't really comment on the endodontic, the endodontic prognosis, but we know there's an absence of symptoms, so we don't need to take a PA, so I think we should safely assume that from an endodontic prognosis, it's quite good as well. In terms of the tooth tissue, again, we don't have a clinical image, but we've got a radiograph, and the caries looks to only extend into the outer two-third of dentine. So in this case, it's not a significant amount of tooth tissue that's affected, and again, I would say that it has a good prognosis. So overall, those three factors, perio, endo, and tooth tissue, I think that the upper right 7 has a good prognosis and is restorable by a direct restoration. Looking at the upper left 5, which is our main tooth in question, again, good periodontal prognosis, high bone, no deep pockets. Endodontic restorability, well, we've got a very small periapical radiolucency. We've got what looks like a really nice patent straight canal. So all of the factors are favourable towards a successful root canal. In terms of tooth tissue, well, we have quite a significant amount of tooth tissue lost, but we're just looking at a 2D picture of a 3D object. So I would say that in terms of tooth tissue restorability, I'd say it's quite fair, but it's very difficult to comment without having a picture of the tooth itself. Obviously, this was my patient, so I've seen the tooth, and I know that it had good restorability and there was plenty of tooth tissue. But I think for the sake of the example, I think in terms of the upper left 5, you would be well within your right and justified to say it has a good prognosis based on the factors we just discussed. Or I think you'd be able to say it has a fair prognosis as well, purely because it needs endodontics. Outline your management. So basically this is talking about treatment planning. It's talking about your emergency phase, your prevention phase, your restorative phase, and your maintenance phase. So in terms of the emergency, well, we have a patient that's come in pain. So we need to kind of see, can we address that and what we can do? So the options for an emergency are we can extirpate the pulp if we have enough time and if the COVID protocol allows us to do so. And that will provide the patient with a pain relief, and it will give them the option for a root canal treatment in the future. Our second option is we can consider an extraction, which is an immediate pain relief, but of course it will leave a young patient with a gap in that area. Some people might mention antibiotics, but in this case they're not justified. There's no spread of infection, there's no swelling, the patient doesn't have limited mouth opening and things like that. In terms of prevention, you'll always say the same things for prevention no matter what the case is. You'll start with oral hygiene instruction and diet advice in accordance to delivering better oral health toolkit. That's your number one thing that you say, because it shows the examiner that you know which guidelines to use basically. In this case, I would say to the examiner, well, the patient has a high caries risk based on the ADA caries guidelines, purely because of the fact that they've got enamel caries absolutely everywhere, and they've got two quite large lesions on their upper teeth. And then I would go on to say, because the patient has a high caries risk, we are justified in giving the patient 2 or more doses of fluoride varnish per year. We're justified in prescribing the patient with 5,000 parts per million fluoride toothpaste. Of course, both if the patient doesn't suffer from severe asthma, which is contraindicated. I would advise the patient uses a 0.05% fluoride mouthwash at different times to brushing, perhaps after eating for a little bit of extra protection. Our prevention phase would also include addressing our gingivitis, so things like plaque and bleeding. Because the patient has 2s, we would consider doing supragingival PMPR and also addressing any overhanging restorations that we can see on the radiographs, for example, like the upper left 6 mesial. And finally, we know that the patient smokes, so we have to provide the patient with smoking cessation advice as well, and see if they are open to quitting as part of our prevention phase. In terms of restorative phase, like I mentioned before, we would say that the enamel caries have the potential to remineralize. So you would discuss things like non-restorative cavity control, which is your high fluoride protocol, and monitor the sites. So basically monitoring them clinically and radiographically. The upper left 5, we have the option for a root canal treatment if they elected to, with a direct or indirect restoration at the end. Or we have the option to extract the tooth as well. Both are completely justified. Discussing space management options with your extraction as well. And with the upper right 7, because it's in the outer 2/3 of dentine, then a mesial occlusal direct restoration will suffice for that as well. In terms of recall, again, always mention if the patient is high, low, medium caries risk, because this will ultimately affect your recall and your radiographic intervals. So because the patient is a high caries risk according to the ADA, my routine recall is 3 monthly according to nice guidelines, and my bite wings I will be taking 6 monthly according to the FGDP guidelines. Of course, if we mention that the patient is elected to have a root canal treatment, then according to the ESE guidelines, I'll do a 1-year radiographic follow-up of that tooth as well. Space replacement options are fairly straightforward. There's only really 3. You've got denture, bridge, and implant. But it all depends on the case itself, and it depends on the teeth either side, the patient's wishes, oral hygiene, and things like that. So for this case, the suitable things I'd offer are you can have no replacement, so a space. And I probably mention things like they won't, because of the amount of teeth they have, they won't lose any function, things like that. They can have a partial denture, be it a critical cobalt chrome, but in the case of replacing just a single premolar, that might be a little bit of overkill. They have an option for a bridge, like I said, so you have a resin retained bridge, you have a cantilever bridge, or you have a fixed bridge, but again, depends on the site of the tooth and the prognosis of the abutment teeth either side. And then you have the option of a private implant as well. And last but not least, a cheeky periodontal question, because a lot of it's been focused on endo. What are the risk factors for periodontal disease in this case? And they're quite straightforward. We can just refer back to the slide in the presentation. The patient smokes. They potentially have poor oral hygiene, although we haven't got a clinical picture, but the patient has 1s and 2s on their BPE. They have overhanging restorations, which are plaque retentive factors. They have depression, which we spoke about earlier, which can adversely affect someone's oral care routine. And they're an infrequent attender, so we're less likely to see them as often, to pick things up early. So yeah, that's it. Basically, that is your endo and perio in a nutshell. A lot of information, a lot of talking from me, but I hope it was helpful. And I hope you got something out of it. Obviously, if you have any queries, please send me a message on Instagram or leave me a comment. I'm more than happy to answer them and clarify things. It's tired, I'm late, but yeah, I appreciate you guys for watching. Please give me a follow on Instagram if you haven't. And next time, I think this time next week when a video comes out, we'll be talking about indirect and direct restorations. So yeah, take care, and I'll speak to you guys soon.